questions section on your GoToWebinar console. At the end of the presentation, we'll have a Q&A session as well, and we'll get to as many questions as we can. But if for any reason yours is not addressed, someone will be able to follow up with you after. Physician informaticist, Dr. Jim Thompson. The content of the webinar today will focus on the challenges of problem list management, the impact it has on clinical workflows and patient care. Dr. Thompson will then examine the ways in which problem lists can be improved and best practices for implementation. So as mentioned before, if you have any questions or comments while our presenter is speaking, please type them into the questions section on your GoToWebinar control panel. And with all of this being said, I would like to pass it over to Dr. Jim Thompson.
Thanks a lot, Jordan. My name is Jim Thompson. I'm a physician informaticist with Intelligent Medical Objects. And although the presentation today isn't about IMO per se, we did kind of want to give you a brief introduction of who we are and what we do. IMO has been the innovator in clinical interface terminology since 1994. We serve more than 500,000 US physicians and other clinicians every single day. We're in 4,500 hospitals. We have something like 70% or so of the market across the United States for acute care facilities. So we've been doing this for a long time, and my particular role within IMO has to do with how the clinician approaches the electronic health record, how the EHR displays for that clinician, and most particularly, my work has been around the problem list itself. So that's what we want to talk to you about today. How do we make the problem list more effective for everyday use? And by making the problem list more effective, make the electronic health record itself more effective. I've been out in the vendor world for about 10, almost 15 years now, and you don't have to go very far to see that there's a lot of criticism around the electronic health record and how it works for clinicians. And this is true for physicians, it's true for nurses, it's true for pretty much everyone across the spectrum of people taking care of a patient clinically within the EHR. And so I want to take a look back by way of intro and sort of look briefly over the history of the electronic health record and maybe why the workflow for the modern clinician seems to be as inadequate as it is. So if you go back pre-1990s, we're all on paper. And as organizations get bigger, as healthcare gets bigger, as systems get bigger, paper becomes impossible as a means through which I can take care of a patient. You can't distribute it. Information sits in little silos. Satisfaction with paper, as soon as healthcare started growing in the 70s and 80s, became very profound. So by 1990 or so, I think all of us have realized that we're not going to be able to take care of a patient in the modern healthcare world on paper. And because of that, interest started growing in the electronic record. And by 2000 or so, there was a great deal of interest in the electronic health record. And you can see that graph here on the screen. Some of you will recognize this as the Gartner hype curve kind of applied to the electronic health record. So by 2000, those of us who were in informatics at the time were starting to get pretty excited about this move toward the EHR and how much it was going to solve our issues around taking care of a patient. And then, of course, reality set in, and over the next 10 years or so, as more and more vendors came online with their different EHR products, we kind of sink down from an enthusiasm standpoint into what's been nicknamed the trough of despair for this hype cycle curve around new technologies. The EHRs had a lot of issues that they were dealing with, and that they were frankly pretty discombobulated from a clinical perspective. And then if you remember back in 2009, Congress passed the ARRA, the American Reinvestment and Recovery Act, and about $26 billion inside of ARRA was devoted just for healthcare information technology. And of that 26 billion, a great deal was devoted toward incentivizing organizations to actually use the electronic health record as meaningfully as possible. And that, I think, was kind of a turning point for the transition from paper into an electronic health record that was truly robust and truly able to support the clinician. But as I've been in the industry over the last 10 years or so and talked to a lot of organizations, I think going forward from there, there's a substantial disconnect between the question, gee, are you really happy as a clinician of how the EHR is working for you, versus the fact that the EHR has to support financial considerations, or becomes a billing-oriented medical record. And right now, I think if you put those two questions to most organizations, you would see that many people feel like there's been so much emphasis on the EHR as a transactional record that you have to use for your billing to stay alive financially, that it feels like the clinical workflow has been left behind and the satisfaction curve for that is much lower. So that's kind of my background about what has happened and why clinical workflow is so important. If we don't have workflow that works for the clinicians, we get clinical dissatisfaction with the electronic health record to a marked degree. That's that first slide that I showed you. Essentially, everything I do around a patient starts with that electronic health record, and within that electronic health record, that starts with the problem list. That's the center pivot point for everything else that I do with the EHR. If I can't start with a clinical picture of what's going on with a patient, I can't order the right tests, I can't communicate to the next physician over the right things, I put that patient's safety at risk. If I miss problems on there, I don't have time to sort through a long, tedious list that happens to have everything on it, because the EHR can aggregate anything I want, but has it in such a cluttered fashion I can't actually focus on where I need to focus. And frankly, as a consequence of that, reimbursement also suffers. Even though the modern EHR is pretty good at getting you pretty decent reimbursement, I still have to be able to focus on the right problems in order to take care of that patient and in order to bill for that patient optimally. All right. What are we trying to solve when it comes to the problem list as the center point of the electronic health record? Well, what you're looking at on the screen right now is an actual problem list that was handed to an emergency department colleague of mine by a patient. She gave him this little printed piece of paper and said, hey, good news, all of my problems are right here. And that may well be true. What you see on the screen is an aggregation of ICD-9 terms. So what I suspect is these had all been culled out of her record and printed off for the clinician. And from the patient's perspective, this is a pretty good problem list. From the clinician's perspective, it's not that good a problem list. It would take me quite a long time to parse through it. There's redundancies on there. The expression of the actual description of terms is odd, to put it politely, and it's close to unusable for me. So let's transition to electronic and see what happens if we take that problem list and we just make it electronic. Well, if all we do is make it electronic in the sense that now it's printed in typeface that I can easily interpret, and it's listed out, and maybe it even has some codes associated with it, that's an improvement over that piece of paper, but it's not enough of an improvement to actually change the way the electronic health record works for me. So we need more than just an electronic listing of every single term that happens to have landed in association with that patient inside of that electronic health record. And that's really where I want to spend the bulk of the presentation today, is talking about how we can get to a world that's better than just simply an electronic listing of all the aggregated data we were able to gather together on a particular patient. Certainly from an electronic standpoint, we can do a lot more than we can do on paper. An electronic health record can create a visual display when it's properly designed, so that I can see, for example, which problems need to be in focus. I can get an overview of all of the different systems that are wrong with a patient. I can have brought forward to me some subset of problems that, for example, might need to exist across time, or that kind of define the overall patient. I can take a problem and I can hide it from view. You see that masked purple indicator at the top right there, because it's so private, I don't want it automatically displayed for everybody that comes by. I can give a clinician little icons that tell them the source of the problem and so on. In a nutshell, there is a whole lot that we can do around the problem list beyond just simply listing it out. I want to take a little pause here because I suspect if most of you have dialed in because you want to hear about the problem list, you may well have a personal opinion about the problem list. So as Jordan said, we're interested in your feedback. So let me take a short pause here and let you complete this poll before I continue.
Thanks, Jim. All right, so which of the following do you see as a major issue for the problem list? Decreased clinician satisfaction, decreased patient satisfaction, patient safety risks, inefficient workflows, or all of the above? I'll give it a few seconds while everyone answers. All right. That's a close out. So Jim, it looks like a majority of people say that it is all of the above.
Well, no surprise there. So let's talk about what we can do about all of the above and maybe some specific steps that we can take as an industry to improve the problem list for our clinicians. The way that I think of the problem list is that it's a dashboard, and I frequently make the analogy to an airline pilot flying a plane or an automobile driver navigating the road. There are thousands of underlying important points, but for me to get through it in an efficient way, I need to have a dashboard that more or less brings everything into a single view so I can focus where I need to focus. And when I use airlines or automobiles as a parallel, or sometimes you'll hear banking as a parallel because they've done so much better with interoperability than we have, I frequently see an excuse for the medical world kind of along these lines. Well, you know, we have special considerations. We got more regulations. We have more sophisticated users, on and on. And so I like to say we need to kind of set those excuses aside and just work on improving the problem list and the electronic health record and not worry too much about the excuses. I mean, after all, if you look out in the airlines, you see that they have every constraint that we have in healthcare. Their practitioners are highly qualified and therefore highly critical of how things need to show up on their dashboard. There is a huge amount of pervasive regulatory requirements. They're in a very competitive environment. They have very thin margins, on and on. So I think that we need to not make excuses. We need to just start working on what we can actually do to improve the problem list. And the second thing that I sometimes see as a barrier when we're talking about what we need to do to the electronic health record is, oh, that would be really nice. That would be a nice to have. But hey, we need to figure out what the ROI is. We need to figure out what the financial improvement is going to be if we put in a particular improvement instead of doing something else, because no vendor can do everything and no organization can implement everything. And so I like to say the most important return on investment you can get when you improve your electronic health record is not better reimbursement, it's better care. It isn't that reimbursement's not important, but it's that the most important ROI is better care, in the same sense that, for example, if you're an airline and your job is to get a passenger from point A to point B, the most important thing you can do is to do that safely. If you can't do it safely, if you can't deliver that passenger to the other side, you haven't done your job at all. And so I like to look at the things that we need to do for the electronic health record from the perspective of what is going to actually provide better care for our patients. A starting paradigm for our company, IMO, is that problem terminology is an interface between clinicians and computers. When I go to an electronic health record and I am taking care of a patient, I'm documenting against that patient, the very first thing I need to do is get a clinical picture of what's going on with that patient into the electronic health record. I have to capture a diagnosis. That diagnosis is going to at least sit on the problem list to become that center point of care. And so I need a way to get from what I need to say and what I want to say as a clinician, I need to get that into the record. The record itself needs to be able to process that information. The record itself is going to be full of various requirements, including regulatory fiats for specific external reference vocabulary. So think ICD-10 or SNOMED or whatever. But if we can get an interface between what I want to say and what ends up sitting not only in the record of that individual patient, but in the aggregated data that I can use to analyze whole populations and improve care. If I can get that interface right, then I have solved one of the major issues of the modern electronic health record. The computer needs to be able to understand what I want to say as a clinician. Think about a specific example to put that in perspective a little bit. So in general, what happens when I'm making a clinical decision is that I gather up the data points and then I combine those into information. So here I have a problem list on the bottom left, and this patient's on a certain number of medications, and the patient's had a certain number of tests done, and I can combine all those data points into the information that this patient has a renal mass, they've got a history of deep venous thrombosis, they're on an anticoagulant called warfarin, and their INR measurement of how much warfarin they're on is out of whack. That's the information that I need in order to decide what to actually do, not just go biopsy their kidney, but biopsy their kidney in the setting of the fact that I have to manage their coagulation data. So if you look at the very foundation of that, you realize the very first thing I need to do is get a clinical picture of what's going on with the patient. Typically from the problem list in a modern electronic health record, and from that pivot point, everything else can flow. So what are the steps that we can do to get to a more effective problem list to help guide us through that decision-making process? Well, at IMO, our first emphasis for the last 20 years or so with respect to terminology has been that we need to understand how clinicians speak. We get it that the electronic health record has to have reference vocabularies to make it work. CCDA, for example, by legislative fiat, must contain SNOMED terms for those problems. Billing encounter is going to need ICD-10 by fiat of HIPAA in order for me to get paid for that visit. But clinicians don't necessarily speak those external reference vocabularies. A physician might describe a STEMI in all of the ways that you see it on the left-hand side here. So the focus for us in terms of the problems that land on the chart is to understand exactly how clinicians speak in the first place. And what that lets us do is keep SNOMED and ICD kind of behind the scenes. So I, as a clinician, might want to say breast cancer metastasized to pelvis. That's what I want to put on the problem list. That's it. And underneath the covers, so to speak, behind the scenes, if that goes off on an encounter for billing purposes, it's going to need the ICD-10 codes you see, and it might need more than one ICD-10 code, typically does for a more complicated diagnosis. On the other side, buried somewhere in the electronic health record, and for purposes of, for example, exporting that problem to a different organization, might need all the SNOMED terms attached to that. But there's no way that I, as a clinician, am going to be able to manage both of those external reference vocabularies, much less all the rest of them. I just want to be able to say what I want to say and move on. So that's been an important focus for us in terms of delivering this idea of letting the clinician capture their clinical intent precisely the way they want to capture it and send it out. Now, I added the slide that you're seeing here just this morning because I was reading the JAMA from yesterday. As you know, JAMA publishes online articles before they publish them out in print. And this particular article was about screening for people who have coronary artery disease, but who don't have any symptoms. You know, they haven't had a TIA, they haven't had a stroke. They're just kind of suspicious as a clinician that they might have bad coronary arteries. And so the central question here from a clinical perspective is, if I screen all these patients, and if all that screening results in an intervention, say a carotid artery endarterectomy, fixing their carotid artery, how much better will that group of patients do? And surprisingly, the answer is maybe not that much better and possibly even worse. And that's not really relevant here, the actual clinical decision. But the point that I want to make is that the authors of this article call out the fact that the reason this is so hard to study for these many years since we've been doing carotid endarterectomies is that the billing codes are not specific enough. Well, what are those billing codes? Well, in the modern electronic health record world, on average for a bill, again by legislation created by HIPAA, I need to drop an ICD-10 on that bill. So what can ICD-10 say about screening your carotid artery? Well, you go to Z13.6. You can do it after this webinar if you like to see how specific ICD-10 can get around this. And the best thing that you can say in ICD-10 about that patient's problem is that they had a screening encounter for, quote, cardiovascular disorders. Well, now I can't go and analyze that aggregated data and see whether or not if I screen for coronary artery disease in my patient population, I can improve care because I can't even find that cohort in the first place. So the kind of term that we need is something much more specific. We need a term that says, this patient had an encounter for screening for stenosis of their carotid artery. I need to be able to say exactly what I want to say as a clinician, both for the care of that individual patient and to improve care across the board in general. But I hope that makes the point that this idea of creating terminology and using terminology that's going to land on the problem list that says exactly what I want to say is absolutely critical if we're going to make the electronic health record robust. The second thing that I've learned over the years is that there is no one way to slice and dice a whole book of problems to serve all the various use cases that particular problem, that particular environment needs to solve. If I'm creating a display, let's say, for example, for a primary care clinician or somebody who just wants an overall clinical picture, I need one kind of display. I need flexibility that adjusts for each use case that I have. So an overall clinical picture, maybe put everything into a given clinical category. But it has to be more flexible than that. I can serve up, for example, if I have the right kind of display, the conditions that you see on the far left that are specifically germane for an anesthesiologist. Or might have a different kind of a group that I use for calling out a very precise subset of problems that I can apply at the point of care for clinical decision support. Or bringing forward from an aggregated database a group of patients that need a very precise set of subset of terminology that defines that particular cohort. And so when I talk to customers, they all kind of agree with this, and all of them say, well, why hasn't that been done? Why isn't our electronic health record better at bringing forward for us the kinds of groups we need for clinical decision support, for mining aggregated data, for displaying the problem list, and so on? And the short answer is that it's quite difficult to do that. We release, for example, about 1 million terms into the electronic health record. And it's actually quite difficult to take this idea of creating little individual modules out of which I can create an aggregated display by combining them for various use purposes and giving me the flexibility that I need. So I'll use as an example of that SNOMED. Let's say that I have a problem on the chart that this patient has an abscess of their pharynx. So if I try to use SNOMED to create the right flexible displays, one of the displays that I want to create is to say, all right, I just want an overall clinical picture with some clinical categories in it. Where does abscess of the pharynx belong? And I try to use SNOMED to create that grouping. The problem that I run into with SNOMED is that SNOMED says, and quite accurately, this might be an ENT problem, a disorder of the pharynx. It might be an abscess, an infectious disease problem. It might be a problem with the digestive tract because the pharynx is part of the digestive tract. And it might be a respiratory problem because the pharynx is part of the respiratory tract in SNOMED, using these groupers as aggregators. So it becomes kind of difficult to use these external reference vocabularies to do it. And that's one of the reasons that it's been so difficult to improve the displays of the problem list in the modern EHR. Here's another simple example using ICD. ICD has a much more linear hierarchy than SNOMED, and so a lot of people want to land on ICD as a way to solve this issue of creating flexible displays. Well, ICD, although it's very linear, is a little bit oversimplistic. Think of it as more a way to sort of categorize things for reporting rather than being very precise about what's actually going on with the patient. So for example, if I had a patient who was hyperlipidemic and they weren't compliant with their statin medications, I certainly want those two problems displayed right together. But if I use ICD, as you can see on the bottom left there, all I get is that the patient can be non-compliant with their medication regimen in general. That doesn't help me get to the right grouping. So the difficulty and the complexity around creating these groupings that give us the kind of displays that we want to create has been one of the major barriers and one of the things that we at IMO have worked very hard to solve. The third thing that I want to talk about that happens to the EHR with specific respect to the problem list is that over time, because the electronic health record tends to be so good at aggregating and not very good at actually parsing out for the clinician the exact things that they want to focus on, we get these big aggregated lists that are full of all kinds of extra clutter. And so one of the things that we need is an effective tool to help clean that clutter up. There are a lot of problems on a typical list that are put on the problem list, but are actually kind of transient in nature. You know, this patient probably isn't still pregnant 15 or 20 years later. She probably doesn't still have appendicitis 5 years after it was put on her record. An upper respiratory infection has probably been resolved as well. And so we need a tool that effectively helps us clean that up, because if we can get the problem list to the right place to begin with, so it has just the right amount of problems on it, it's much easier to process. And then lastly, what we would really like to do is get to a problem list that can associate all sorts of relevant information in the chart for us. We want a problem list that says, back to that triangle that I showed earlier that you see on the bottom left here, hey, here's a problem, and relevant to this problem, here are the medications that you might want to focus on if you're focusing on these problems. Here are the labs that you might want to focus on if you're focusing on these problems. And that's another thing that we've been solving here at IMO, to say it's not just the display of the problem list itself, but it's the whole package of information that I can display for the viewer on the screen so that they can rapidly get through exactly what's going on with that particular problem for that particular patient in the overall context of their care. Here you see diabetes mellitus, and I'm just using this as an example with a sample electronic health record. But for example, with respect to diabetes mellitus, what I'm interested in is all of the medications that have been used that might be germane to diabetes, and whether or not the patient is still on them. And then, oh, by the way, can you go into the labs and cull out the labs for me and tell me if this patient has had any labs that are particularly germane to diabetes, their glucose perhaps, their hemoglobin A1C, and so on. And then bring all that forward to me in a single visual package so that I can rapidly process just from the problem list as my center point of care, all the things that I need to know about that particular patient. So with that, I'm going to pause here and give you another poll question, and then I'll come back and try and wrap things up.
All right, thanks, Jim. So if everyone can direct their attention to the screen, what tools does your organization use to enhance the problem list? Is it native EHR tooling, homegrown solutions, problem list categorization tools, problem list cleanup tools, or none? I'll give it a few seconds while everyone is responding. All right, just a few more seconds. Okay. All right, Jim, it looks like a lot of people are saying native EHR tooling and none. So like that.
Okay, well, thank you. I just want to wrap up here and leave time for any questions. But if you put it all together, the key points that I want to make is that first we have to be able to bridge the gap between what the clinician wants to say and what the electronic health record needs as coded language. That's the very first step in creating a more effective problem list. I want to be able to say exactly what I want to say, capture my clinical intent exactly, and have the electronic health record still know what I said, and frankly, still be able to comply with the regulatory compliance. The second thing is I don't want just a single way, so to speak, to display the problem list. I need to have it presented in a way that's very flexible according to both the user and the use case involved. You know, I may need one subset of those problems for good clinical decision support, another subset of those problems to define a particular category, another subset of those problems for a given specialty that's viewing the problem list, and so on. And then I need tools to clean and simplify the problem list for the reasons that I mentioned. Across every large organization that we see, the problem list sometimes gets so cluttered that even if you organize the whole thing, it's still almost impossible to parse it out and focus on where you need to actually focus. And then finally, I need a problem list that lets me sort of hot link into the rest of the chart and see the other components that are in the chart that are germane to that particular problem and bring them all into a single dashboard so that I'm not going from place to place to place to try and piece together that information myself. If we can do all that, then the problem list is a much more clinically meaningful tool. It will increase physician satisfaction, and to my own passion, increase patient safety. So with that, let me open up to any questions that anybody has for me. I love what I do here with IMO, and I love what we do as a company. And we are, as a group, very passionate about both the problem list and terminology in general.
Awesome, thanks, Jim. Yeah, if you have any questions, feel free to put them into the questions section of the control panel. Just please excuse any brief silence as we review and we'll answer. So Jim, I did see a question came in. Who at your organization should manage the problem list?
Jordan, can you repeat that for me one more time, please?
Yeah, who at your organization should manage the problem list?
You know, I would have to say from the vendor's perspective, we try to stay pretty neutral about governance issues. But one of the things that we have noticed where we're able to help an organization sort of properly categorize their problem list is that issue of who's going to handle it doesn't necessarily have to fall to, say, the hospitalist on the inpatient side, which is where it normally falls, or the primary care clinician on the ambulatory side. You know, certainly you want to keep those people in the loop, and they tend to be the ones that are kind of managing the whole patient from a central perspective. But what we found is that if you can properly categorize the problem list, it becomes much easier to federate out the management of that problem list to everybody in the organization. So your orthopedist is not going to look over a 30 problem list to figure out which of those problems are ortho in the first place, and of those which are either redundant or don't need to be on it because they've expired. But if you can narrow that down so that that problem list has an ortho category on it, and there are just 5 problems for them to manage and they're all right together, well, then you can federate it out by saying, look, you don't have to do the entire problem list, but you can manage this little part of it for us. And I think that's the way that we get to a better problem list across organizations. So yes, the hospitalist inside the hospital and the primary care doc in the ambulatory world can still do the final cleanup, but each individual area with a properly organized problem list can help you out. Jordan, I see another question on here about agreeing with the problems on the problem list, but where do I find the solutions? Am I reading that question correctly?
Yes.
Yeah, okay. So I think what's being addressed here is, hey, this is really great. You're right that that there are all these issues, so to speak, with the problem list. I think that's what they mean with the problems with the problem list, not literally the term itself necessarily, but all these issues. I don't want to turn this into a pure IMO presentation, but I will say that our organization, among others, has worked very hard to address some of these issues. And so if you start with vendors like us who say, we can help you with some of these issues, I think that there are vendors out there working very hard to make the problem list better, to make the way the electronic health record works better. And I would certainly point to us as one place to start for those solutions. The next question is about considering or creating any FHIR apps to manage the problem list. Yes, in a word, yes, if you're asking us in particular for IMO. So for example, I showed you a little snippet of a cleanup tool that we've been working on and delivering out into the marketplace. And that cleanup tool does leverage FHIR APIs in order to make it work. And certainly going across the industry with the broad interest in FHIR, I think that will continue to improve as experience on both sides comes to bear and can better leverage all of the things that FHIR can bring us for being able to better interact as a given third party, for example, with a sourcing electronic health record. The next question specifically asks, do you have a program that cleans current lists? So again, I don't want to make this presentation a marketing presentation per se for IMO. That's certainly not our intent here. Our intent is to give you a relatively vendor neutral view across the industry. But the short answer to that question is yes. We do have a cleanup tool that we created for the express purpose of trying to improve the content of the problem list itself. The next question is, what techniques using the problem list to enhance charting? Is problem-oriented charting valuable, and what are the essential elements to have a successful problem-oriented charting? This is a great question, and it goes to one of the concepts that I was trying to address here, which is that you have an overall problem list. It's got 30 things on it. Maybe you've already cleaned it up and it still has 20 things on it, and I want to do problem-oriented charting against it. Well, one of the kinds of things I need under that broad category of flexible displays, depending on the use case, is the ability to cull out from that problem list the specific area that I want to focus on for my problem-oriented charting, and within that whole list to be able to extract just what I want to document against. And so, the idea there is to have a flexible group or a flexible display that can extract a specific group and put it in my problem-oriented charting workflow. This solves a lot of problems, a lot of issues, I should say. One of the issues that we see commonly is that if somebody has addressed back pain or cardiac arrhythmia or anything else several different ways on a problem list and they're redundant, what happens is that a given note in problem-oriented charting gets attached to 4 different but redundant problems. And so if we can bring the right subset in the first place forward to the clinician who's doing the problem-oriented charting, 2 things happen. One is you get a much better embracing of problem-oriented charting because I can go to a single place, a single problem, and see all the notes attached to that general area of concern. And then the second thing is I don't have to manage 4 different problems that are all around exactly the same thing. So there's kind of a 2 or 3-fold step to that. One is getting the problem list as clean as possible in the first place, so I don't have a lot of redundant things. And the second is culling out a subset. Maybe I'm an ear, nose, and throat specialist, and I want to focus on those problems in that original problem list that are germane to ENT. So I need to have a subset of those problems brought forward to me. And then the third thing is actually attaching the note to that particular problem. So yes, I think it's really important. I think it can be done if someone's creating the right content. And again, for what it's worth, that's one of the areas of focuses we've had here at IMO, is creating the kind of content that drives that kind of workflow for the relationship between the problem list itself and the problem-oriented charting world that everybody wants to get to. The next question is, how do we overcome the limitation of our electronic medical record? This is also a topic near and dear to us at IMO, because fundamentally we don't create the electronic health record itself, and we recognize as a third-party vendor, so to speak, that we're dependent on the actual electronic medical record that's being used in order to implement any content that we create, for example. One of the things that I've learned is that it makes an enormous difference to your EMR vendor if you personally lobby them for any functionality that's not there. I know it may not seem that way all the time, but we talk to the leaders who are behind development of the electronic health record in general, and I can assure you they really do care what their customers are saying. In fact, sometimes it frustrates us that we go to them with a good idea and they'll say, that's a good idea, but hey, by the way, we need to hear that from a customer because we don't want to hear it from a third-party vendor, or at least we don't want to hear it only from a third-party vendor. So don't hesitate to speak up. The second thing that I think is an important way to address that is to make sure that you're using your electronic health record currently in an optimum way. You'd be surprised how many organizations have a functionality that's buried inside their electronic health record and they don't even know how to turn it on. And then the last thing I want to make about that particular point, the last point that I want to make is pay attention to where you're putting your money. So we, as a vendor, frequently have really good ideas that really are going to improve the workflow for clinicians. and how that electronic health record is going to work for that clinician. And we'll put it in front of an organization, and the very first question we'll get is, okay, can you give me an ROI slide for this? And usually that's a request for ROI in terms of, if I put this in, you know, how many more dollars will I see, or how many dollars can I take out in cost if I put in this particular solution? And one of my passions in terms of talking to customers is to try and move them away from only looking at pure ROI. We get it that a financial ROI is absolutely critical. Not interested as a vendor in bringing you something that doesn't help your ROI. But a financial ROI shouldn't be the only consideration when you're looking at ways to improve your electronic health record. I think a focus on clinical care, improving healthcare itself, better aggregated data, fewer missed problems that affect safety for an individual patient and so on, are just as critical as is a financial ROI. The next question is, my issue in getting providers to understand how important the problem list is for all the reasons you outlined. Any tips or resources would be helpful. I certainly would offer IMO as a resource. We love talking to people in the clinically implemented world, so to speak. We have lots of clinicians here at IMO, and we love getting on meetings and talking to people about what their issues are. And we're so broadly penetrated across the industry that there's a pretty good chance that the electronic health record that you're working in is either one that we partner with already or one that we're considering partnering with. So we certainly want to offer ourselves as a possible resource for that. Inside the organization, I would say it gets back to how you want to do governance at your particular organization. And that's a difficult question for me to answer as kind of an outsider for the organization, but certainly you want to ensure that any changes that you make have a relatively straightforward transition. You know, we clinicians don't like a huge change in how we do things. And you want to make sure that your communication tools inside your organization kind of come from leaders who it appears to the organization are clinically oriented leaders. So folks like your CMO and your CMIO and your physician advisory council. And if you don't have a local physician advisory council to your organization, certainly been my experience that that's a very, very valuable initial place to start, so that the impetus for some of the changes that you need to make to your electronic health record, and maybe some of the components that you need to acquire to make it work better, the impetus for that feels like it has a groundswell of support from physicians actually working inside the electronic health record itself on a daily basis. The next question is, currently providers use management of the problem as outside their workflow, see management of the problem as outside their workflow, and they don't see personal benefit from spending time on it. How can we help them see personal ROI? Sometimes I like to say I don't have a pat answer for every single question, and this one is brilliant. I mean, I was in a CMIO role for about 10 years, and the issue around the problem list sort of boiled down to the fact that everybody wanted a great problem list, and not everybody was willing to be the one who actually created that great problem list or improved the content of the current problem list, even though they wanted it. So it's sort of, I like to say, it's sort of like when you tell all your kids to clean up the kitchen, nobody cleans up the kitchen, right? Some of the things that I think can help address this are things like federating out the workload. As I mentioned earlier, if you have a well-organized list, it becomes a lot easier to say, you, Mr. Specialist, for example, don't have to clean up the whole thing, but can you at least do, you know, your little bit of the laundry? And then I think the rest is probably more organizational change, which is not my area of expertise. But if you have the right tools in place that make it relatively easy to, for example, clean up the problem list, it's a lot easier to mandate at an organizational level how important it is to get those problem lists cleaned up. But having said that, I agree that this is a really difficult issue, and it's kind of a tender one as well, because I may work for quite a while as a primary care doc to clean up the list and feel like I never got any sort of credit for it, and I never got compensated for the time that I used to do that. So you might think of more creative initiatives, such as literally assigning somebody to do that and paying them for their time. Those kinds of organizational things, I think we probably on our side don't want to weigh in too heavily, but I certainly agree with you that it is an issue where your organizational approach and paradigm and governance all weigh into that.
Jim, these questions are great. Just a reminder, everyone, we have a few more questions that came in, but if you have any additional ones, feel free to put them in.
The question is this capability that it's already there, or are you working toward? I love using IMO as a dashboard, but I don't see a way to get the labs or relevant meds into the assessment. I use NextGen. So first of all, I want to steer away kind of gently from making comments about any particular electronic record. We have been partners with NextGen for a long time, and we have absolutely loved some of the things that we're able to do inside of NextGen. And I'm speaking of IMO collectively here, have a very good relationship for the leaders at NextGen, including the clinical leaders who help drive what NextGen is doing. So I can't answer the question with specific respect to NextGen, but I can tell you that our solution, for example, in NextGen goes a long way towards solving some of the tension between how I manage problems, how I see problems, how I can focus on problems that affect my reimbursement, whether or not I've recently documented on an HCC that I need to document on before the end of the year, and so on. And certainly be happy to have you reach out to one of our folks here at IMO who works with NextGen to make sure that you are at least inside of NextGen getting some of the basic tools that I've talked about here, because they do exist from our standpoint in that particular electronic health record, and we're delighted to show them to people. Hi to Dr. Thompson, Terry Hayes, MD. Oh, I take it that this is a personal question. So thanks, Dr. Hayes from Baptist Primary in Jacksonville. Question is the various descriptors with the same ICD-10 code. Makes for a lot of duplicates and a very long problem list. Help us out. Comments. I have a whole lot of comments around that. We do have tools that help you get through that. Our terminology is constructed in such a way that you can't necessarily define a duplicate by what its ICD-10 attachment is. We are generally speaking quite a bit more specific for what we want to say than is ICD-10. And one example was back on that problem list that I showed earlier. I'll just flip back to it here, if you'll forgive me for this. It was the one from JAMA, this one. So if somebody were looking for a term where they wanted encounter for screening for stenosis of the carotid artery, we would have to map that to Z13.6, the ICD equivalent for it, because ICD-10 cannot say what we can say on our side. And so if you were to look up, all the IMO terms related to Z13.6, you would see a whole bunch of them. And why are there so many Z13.6s? Well, the answer is that our terminology is more specific than ICD-10. And so when you look up dupes by ICD-10, you're not getting duplicates that are actually saying the exact same thing. Having said that, we do create some duplicates where it's different ways to say exactly the same thing. And so this whole idea of how to resolve those duplicates and manage them inside of your electronic health record is a little bit tricky. But that cleanup tool that I showed you will identify those, as well as if you use our clinical categorization, what happens is you kind of inoculate the chart against getting all those duplicates in the first place, because it's very easy to see amyotrophic lateral sclerosis is already on there. I don't need to put Lou Gehrig. It's two things saying exactly the same thing, and you can see immediately under neuro whether or not the patient has that condition. So kind of a longish answer for it, but we'd be happy to hop on a call with you, Dr. Hayes, and parse out some of it a little bit more, and thank you for that feedback.
All right, Jim, we have one more question.
Okay.
Does patient engagement enhance the value of the problem list, motivate clinicians to improve quality of the problem list?
Let me have you ask that one more time so I can process it.
So does patient engagement enhance the value of the problem list? It's a twofold question, so we'll start with that.
Okay, so going forward, as all of you know out there in the real world, patient engagement is becoming increasingly important. And I think the short answer is a resounding yes. You know, we're getting to the point where patients can even see their own problem lists. I can certainly see mine here in Denver at University of Colorado Health. And so what the content is on that problem list definitely helps to engage that patient in their care.
Got it. And would that be motivation enough to improve the quality of the problem list?
That's an interesting question. And I'll leave it as kind of a hypothetical question, but I will say that the ability to present that problem list to the patient is definitely motivation on the clinician side to make sure that it's an accurate and organized list that has the right terms on it.
Perfect. All right. Well, I think we reached the end of the road for questions. And so we're going to go ahead and close out for today. And I hope you found this information in today's webinar useful. Thanks, Dr. Thompson, for presenting in a way that was so digestible. And so if you want any more information about IMO solutions, please contact your IMO client and executive. You can also email sales@imohealth.com. Thanks so much for attending, and I hope everyone stays safe out there.